Welcome back to the deep dive, the Plastics in Practice edition. You know that feeling? A new mandible fracture hits the list? Seems straightforward, maybe. But the evidence guiding how you fix it, that's where it gets complex.
It really does. The tech's moved on leaps and bounds, plating systems, imaging. It's impressive.
But staying current on the why, behind the choices, the actual evidence, that's how we nail the outcomes.
Exactly. So for our residents and attendings listening in, that's our goal today. We're cutting through the literature, pulling out the latest evidence on managing these fractures.
Focusing on those clinical pearls, right?
Yeah.
Things you can actually use for decision-making for patient care.
Precisely. The why and the when of what we do now.
Okay, let's start foundational, the anatomy, that mandible. It's got key parts we need to know cold.
Right. Condyle, coronoid, ramus, angle, body, symphysis. Standard stuff, but critical for planning.
And before fixation, we have to think about what we might injure. The nerves, the vessels.
Non-negotiable. That inferior alveolar nerve and artery sitting right there in the medullary canal.
We always think about keeping plates below the tooth roots, but where exactly is that nerve usually?
Good point. It often tracks a bit closer to the buccal cortex than you might think. So, when you're drilling those holes, be mindful.
And moving forward, say, for a body or symphysis fracture, that vestibular approach.
Then it's all about the mental nerve. Exiting right below the second bicuspid gives sensation to the lower lip.
So for the residents planning that incision?
Yeah, deep dissection, careful retraction, you absolutely have to protect that nerve. Post-op numbness is one thing, but temporary marginal mandibular weakness from maybe stretching things too much during exposure, that's a bad outcome.
Okay, anatomy down. Now, the really interesting part, I think, biomechanics. Why these fractures displace the way they do, it's not random, is it?
Not at all. It's all about muscle pull. You've got these two strong opposing teams of muscles acting on the mandible.
Team one being the closers.
Right. Your muscles of mastication, masseter, temporalis, pterygoids, huge upward closing force.
And team two pulling the other way.
Exactly. The suprahides, digastric, mylohide, and others, they depress the mandible, open the mouth.
So break the bone.
And those forces dictate the displacement, predictably. The posterior segment gets pulled up and in by the closers,
while the anterior segment gets pulled down and back by the openers?
Precisely. Understanding that vector mismatch is the absolute key. It tells you exactly how you need to push or pull during reduction to get things lined up again. That's reduction 101.
Let's shift gears a bit. Epidemiology. Who gets these fractures?
Mostly young men, typically 25 to 34. That's the peak incidence.
And there's a really strong link with substance abuse, isn't there? The numbers are quite high.
They are startlingly high, depending on the study, somewhere between 29 and 55%. It's a significant factor.
And the mechanism often tells you the fracture pattern, right? Sort of a board prep pearl.
Definitely. Think about the force vector. Anterior impact, like an MVC.
Symphysis, maybe parasymphysis. Often bilateral condyles, too.
Exactly. The force transmits back, lateral impact, like a punch.
More likely angle or body fractures.
Right. And speaking of MVCs, here's a critical safety point, especially for anyone working trauma.
Mandible fractures in those patients often mean badness elsewhere.
A huge red flag. The literature shows a really high association, like 64.8%, with other severe, potentially life-threatening injuries. And sadly, about an 8.1% mortality rate in those MVC cases with mandible fractures.
Wow. So it's a marker for significant energy transfer. Okay, patient assessment, history, physical. What's the one thing almost everyone complains about?
It's usually pretty simple. My teeth don't fit together. Malocclusion. That's your number one sign.
So imaging. We need to see the fracture. Is the panoramic still the go-to, or is it CT all the way now?
That's a great practical question. Traditionally, yeah, we needed two views. Panoramic is still good, especially, and this is level 1 evidence, diagnostic 1, for seeing tooth root fractures.
Okay, so don't ditch the panoramic if you're worried about teeth involved in the fracture line.
Exactly. But
it
can definitely miss things, especially fractures further back, posterior ramus, condyles.
That's where CT shines.
Absolutely. CT's really become the standard, particularly in trauma settings where you're looking for other injuries anyway. Its sensitivity for catching mandible fractures is basically 100%. Panorex is more like 86%.
And the 3D reconstructions.
Invaluable. Really helps you visualize displacement and plan your fixation strategy before you even scrub in.
Okay, principles of management. Let's talk timing and antibiotics. Logically, you see an open fracture, especially through the mouth. You want to fix it ASAP, right? Prevent infection.
That's the instinct, for sure. And we do want to fix them promptly for patient comfort, function, getting them eating again.
But is delaying fixation, say waiting a couple of days, truly detrimental from an infection standpoint?
This is where the evidence is maybe counterintuitive. Multiple studies, including some level 3 evidence looking at risk, have compared early versus delayed fixation, early being less than 48 or 72 hours.
Yeah.
And they found no statistically significant increase in infection rates, even when fixation was delayed beyond 72 hours.
Really? So that pressure to rush to the OR within hours to prevent infection isn't strongly evidence-based?
For infections specifically, the evidence isn't there. Now, there's a caveat.
Oh.
One large study did find an increase in non-infectious complications with delay. Things like marginal mandibular nerve issues, maybe subtle malocclusion, persistent pain.
So while infection might not be the driver for immediate surgery, there are other good reasons to fix them reasonably promptly, like preventing those other issues.
Exactly. Patient comfort, minimizing nerve stretch or irritation, getting the occlusion perfect. Those argue for timely, though perhaps not emergent, fixation.
Makes sense.
Yeah.
What about antibiotics?
Yeah.
Given the contamination through the mouth or skin?
Yeah, current standard practice is clear. Give antibiotics as soon as possible for any open fracture. And remember, any fracture through a tooth-bearing area is considered open.
Standard choice. Penicillin.
Usually penicillin G or maybe ampicillin sulbactam, clindamycin if they're allergic.
But what's the quality of evidence supporting this?
Honestly, it's not great. Level 4 evidence, therapeutic 4. So, expert opinion, case series, not high-level trials.
But we still do it.
Yes, because when you look at the bigger picture, the aggregate data, cohort studies, they strongly suggest some antibiotic is way better than no antibiotic. Infection rates plummet from maybe 4.5 to 62% without, down to 1.9 to 29% with.
So it clearly helps, even if we can't definitively say which drug or dose is absolutely optimal based on level 1 trials.
Precisely. The benefit seems clear, even if the specifics are based more on convention and broad-spectrum coverage principles.
All right, patient stable, imaged, maybe getting antibiotics, time to fix it. The guiding principle is always restoring their bite, right? Their pre-injury occlusion.
That's goal number 1. And the philosophy has really shifted towards internal fixation, allowing early movement. The ASIF principles.
And within fixation, there are different philosophies, rigid versus functionally stable.
Correct. Rigid fixation uses heavier plates, maybe multiple plates, aims to completely eliminate motion at the fracture site, allows primary bone healing, no callus.
Versus functionally stable.
That uses typically smaller plates, often just one, placed strategically along lines of tension. It allows some controlled micromotion, which stimulates secondary bone healing callus formation. Think Champy technique.
Okay, let's apply that. Isolated fractures, body, or symphysis. Pretty common.
Yep. Approach is usually intraoral, vestibular incision. Gotta protect that mental nerve we talked about.
And fixation choice.
Often, functionally stable is preferred here. Maybe a single, strong mini plate, like a 2.0 millimeter plate, placed just below the tooth roots along the ideal osteosynthesis line, sometimes combined with arch bars for temporary stability.
What about using 2 plates, or locking plates is more always better?
Not necessarily. There have been good studies, level 2 therapeutic evidence comparing locking versus non-locking plates.
And the verdict.
Locking plates seem to result in better post-op bite force, which is a nice functional win, but complication rates, pretty similar.
So the locking feature might add some biomechanical advantage, maybe helpful in weaker bone, but doesn't drastically cut complications in standard cases.
That seems to be the takeaway. And don't forget, lag screws, excellent for oblique fractures, provide great compression, but
Technically demanding.
very. Need the right fracture orientation and skilled hands. Not for every case or every surgeon.
Okay, let's move back to the angle. The high-risk zone, highest complication rates, you've got the nerve nearby, wisdom teeth often involved.
Yeah, infections, non-unions. The angle is notorious. But this is where understanding those biomechanics really pays off. Remember the masseter pulling that posterior segment up?
Right.
Champy's work was seminal here. He showed that a single 2.0 millimeter miniplate placed high on the superior border along the external oblique ridge,
Just one small plate.
just one, placed correctly, it acts like a tension band. It directly counteracts those elevator muscle forces and provides functionally stable fixation.
And the evidence on this technique.
It's strong. Level 2 therapeutic evidence, studies comparing it to 2 plates or older methods like MMF alone, found the single superior border plate was not only easier to place but had the lowest complication rate.
Wow. So simpler can be better here.
In this specific location, based on the biomechanics, absolutely. It's a really elegant solution.
What if things are more complex? Bilateral fractures, maybe spanning the midline, or comminuted fractures where the bone is in pieces.
Okay, stability becomes the main concern. For bilateral fractures, the general recommendation is you need more robust fixation on at least one side.
Meaning a bigger plate.
Yeah, maybe a stronger 2.4 millimeter plate, possibly locking, especially if it's crossing the symphysis or parasymphysis region where forces are high. You might still use a standard champy plate on the angle fracture on the other side.
And if it's truly comminuted, or there's actual bone loss, a gap.
Then you need load-bearing fixation. The plate has to carry the entire functional load because the bone can't.
So reconstruction plates.
Exactly.
Yeah.
Large profile, strong reconstruction plates, often locking plates. They need to bridge the entire zone of comminution or the defect.
And how much bone purchase do you need on either side?
The rule of thumb is solid fixation into good bone proximal and distal, typically aiming for at least 3 screws in healthy bone on each side of the fractured segment.
What about bone grafting those gaps?
Important point. If the wound is dirty, significantly contaminated, or the soft tissue cover is poor, you delay the bone grafting. Get the soft tissues healed, control infection risk, then consider secondary grafting if needed.
Makes sense. Let's tackle the condyles. Up to 35% of all mandible fractures.
Yeah.
And this is often the big debate, right? Open versus closed treatment.
It really is. It's probably one of the most debated areas. Open reduction aims for perfect anatomic alignment, restoring vertical height, hopefully preventing long-term malocclusion or TMJ issues.
But the downside.
The surgical approach is Risdon, preauricular, retromandibular. They put the facial nerve at risk. Even transient palsies, usually neuropraxias, are common, plus scarring.
So when do you lean towards closed treatment? MMF or guiding elastics?
Current thinking reserves closed treatment for a few scenarios. Definitely for highly comminuted fractures within the joint capsule. Also for minimally displaced fractures, especially if the patient has little to no change in their bite.
So if the occlusion is good, maybe leave it alone.
That's often the approach. Manage them with 2 to 3 weeks of MMF, then physiotherapy, active mobilization.
And open reduction?
That's generally reserved for significantly displaced fractures, especially subcondylar fractures where the condyle is pulled way out of position, or if there's significant malocclusion that won't correct. But, and this is key, only if the surgeon has the specific training and comfort level with the necessary approach.
It sounds like there's no single right answer backed by overwhelming evidence here.
You've hit the nail on the head. Multiple Cochrane reviews have looked at this, and the conclusion is always the same. There is no high-level evidence to definitively prove that open treatment is superior to closed treatment, or vice versa across the board.
So it comes down to fracture pattern, patient factors, and surgeon experience.
Largely, yes. It's a complex decision weighing the risk of nerve injury against the potential benefit of perfect anatomical restoration.
Lastly, the edentulous mandible. No teeth to guide the reduction. How does that change things?
Well, the need for absolutely perfect millimeter-level reduction is lessened because there's no dental occlusion to restore, but stability becomes even more critical.
So options.
You can still do closed treatment, gunning splints wired in, maybe external fixation if the bone is very atrophic, or even using the patient's own dentures as splints if they fit well.
Or open reduction?
Yes, and if you go open, the trend is definitely towards more rigid fixation, often using those large reconstruction plates we talked about for a comminuted fracture.
Boy, so rigid.
Because without teeth interlocking, the hardware has to provide all the stability against muscle pull to allow the patient to hopefully function reasonably early.
But again, is there solid evidence that ORIF is definitively better than closed methods here?
Similar story to the condyle, unfortunately. High-level evidence comparing the outcomes is lacking. So the choice often depends on the patient's ability to tolerate closed methods, the quality of the bone, soft tissues, and again, surgeon preference aiming for early stability.
Wow, okay. That covered a huge amount of ground, a really practical tour through mandible management. Before we finish, let's crystallize those key takeaways. 5 points for our listeners to remember.
Absolutely. Let's boil it down.
Muscle vectors are king. Remember, superior posterior pull versus inferior anterior pull. It dictates your reduction maneuvers.
Got it. 2.
Imaging. CT is the standard for trauma and posterior fractures. But PanRx is still your best bet for checking tooth roots. That's level 1 diagnostic evidence.
Okay.
Timing. Delaying fixation doesn't seem to spike infection rates based on level 3 risk evidence, but fix promptly to minimize non-infectious issues like nerves problems or malocclusion. comfort is key too.
Makes sense. 4.
Angle fractures. Think Champy. That single superior border miniplate often has the lowest complication rate. Level 2 therapeutic evidence supports this elegant fix.
And 5.
Comminuted fractures or bone gaps need load-bearing fixation. Big plates, bridging the defect, 3 screws in good bone, proximal and distal.
Fantastic summary. So, reflecting on all this, we have sophisticated techniques, advanced plating systems, 3D planning.
Right.
Yet, for many core questions, optimal fixation, timing, open versus closed condyles, the actual evidence level is often quite low. Lots of level 3, level 4 data. What's a final thought for our listeners navigating this?
Look, it highlights a persistent challenge in surgical research. The need for well-designed, standardized, high-level clinical trials is obvious, and it's been pointed out by Cochrane reviews for years.
But those trials are hard to do.
Incredibly hard. So until we get that definitive level 1 evidence for everything, what do? You have to combine the best available evidence, even if it's not perfect, with fundamental principles, your specific training, your accumulated experience, and careful clinical judgment for each individual patient. That synthesis is the art and science of what we do.